Emergency Medicine regional rounds. Now, just a reminder that this session will be video recorded so that it can be archived. If you have any questions, feel free to use the chat box for Zoom, and we will get to those. So today, it's my pleasure this afternoon to welcome Dr. Colby Oitment, who will be giving us a presentation around revisiting spinal emergencies, cervical and thoracic myelopathies. So Dr. Oitment is an orthopedic spine surgeon at the Hamilton General Hospital, specializing in trauma surgery, revision surgery, and adult spinal deformities. He completed his orthopedic training at McMaster and fellowship training in adult spine surgery at the University of Toronto. And he is currently completing his master's in health research methodology at McMaster University. So thank you for taking the time today, Dr. Oitment. We're eager and happy to learn more about this important topic.
Thank you so much, Rob. So can you still see my screen here? Am I sharing in presenter mode here still?
Yep, we can see it.
Okay, great. Yeah, thank you so much for having me. It's a real honor, and I have a topic here which I think is extremely important because it's so easy to miss, and it's so difficult to get the diagnosis. So I thought if we just bring it up to everyone's attention, then it's on everyone's radar, and we've talked about it. So I'm going to talk about some of the different spinal emergencies, but specifically sort of focus on cervical thoracic myelopathy today. So I'll go through sort of what we're talking about, why it matters, and then sort of we're going to talk about some of the basics, review the anatomy again, and why myelopathy is so hard to diagnose and why it's so easy to miss, and then some tips and tricks I have for like an emergency room setting, like a quick physical exam features and history features that can help catch some of these cases. So I just want to start with a case to sort of kick it off. So this is a 39-year-old female. She came in with really a non-specific constellation of symptoms. So they included lower back pain, falls, urinary urgency. She really had no perineal symptoms. She had no upper extremity symptoms. Review system essentially negative. She's otherwise healthy. And on exam, she has very dull sensory deficit in both legs. It's non-dermatomal. She's able to move her legs in bed and her arms as well, but she's a little bit weak in the legs, about a 4 to 5 throughout, and her rectal tone is intact. And the question is, so what would be the next steps in terms of history? Does the patient need imaging? And I've sort of cleverly and deliberately left out the key pieces of the history. And this is something I might get from one of my residents. This is a story, but this is missing the key pieces of information that are necessary to make that decision on in terms of what imaging needs to come next, what modality of imaging, stuff like that. So we'll come back, we'll revisit this at the end. But essentially, she had a lumbar MRI, which is normal. And then the patient was discharged. She actually returned to hospital 5 times with progressive falls, gait instability. She got worked up for Guillain-Barré, which is negative. She complained again on subsequent visits, patchy sensory loss, subjective weakness in the legs, again, falls again. And then in December, she actually had a fall. And finally, at that point, she had total paralysis in the lower extremities, and complete imaging was obtained at that point. And so here you can see, this is a mid-sagittal CT scan of the thoracic spine and lower cervical spine here. And this is the corresponding T2 weighted sagittal MRI. And you can see this abnormal bone formation within the canal. So we call this ossification of the posterior longitudinal ligament. The diagnosis there isn't so important as it's just simply cord compression. So she's got thoracic myelopathy essentially, right? And so she eventually had a fall and had this spinal cord injury from that. The cervical spine looks normal, except you're seeing down here what was reflected in the top of that thoracic spine imaging before. And so she underwent this big surgery, decompression fusion late in the evening. And then she's had some recovery in the legs, but a 2 or 3 to strength on the grading scale there at around 3 months. And so the question at the end, so we'll review this at the final part of the presentation, but what are the symptoms of cord compression myelopathy? Why are cases like this so easy to miss and with repeat presentations to the emerge? And what specific questions and exam features could be done to catch these or help catch them, even though they're still tricky to catch? And so a bit of a facetious question here, but like what happens when you pinch a nerve? And so the answer to this really depends on what nerve and what you mean by nerve, and then how quickly you pinch it. So if you pinch a single nerve root, you get a radiculopathy or a sciatica. And these are very easy to diagnose because they're painful, and patients produce a very reliable history. If you compress the cauda equina, so anything below the conus, and you obstruct the entire cauda very quickly, you get this cauda equina syndrome, which is, I think, on everyone's radar. And so if you compress the cauda equina slowly and usually degeneratively and progressively, you get more of a neurogenic claudication picture. If you compress the spinal cord quickly, you can get a spinal cord injury. And I think we're familiar with the different injury patterns for spinal cord injury. And the final one is sort of the slow progressive compression on the spinal cord, which is the hard one to pick up, which is the myelopathy. And so I think all of these would be easily detectable in their own right, or reasonably detectable in the emergency setting. But I can tell you the spinal cord chronic compression producing myelopathy is a tricky one, and it's often emergent. So we'll go back to some of the basics. So the symptoms produced come in a constellation, and it depends if you're pressing on the spinal cord or the cauda equina. So the spinal cord itself produces upper motor neuron symptoms, and not all of these that are in the textbook are going to be reliable in the emergency setting. So the upper motor neuron symptoms sort of described, for example, increased tone. Well, I mean, if someone has cerebral palsy, increased tone is very easy to pick up. If someone has an old stroke in the brain, the tone is, they're very rigid. Someone with myelopathy, you're not going to detect increased tone unless you're maybe an experienced neurologist. So that symptom or sign, it goes out the window, I think. Hyperreflexia, clonus, Babinski are all very good, and I use those a lot. The non-dermatomal sensory loss, that sort of thick skin that they get distal to that sensory level, is a good one. And then weakness as well, but that's really not specific. That could be upper motor neuron, conus, lower motor neuron. And then decreased coordination. Again, that's kind of hard to test in the emergency setting. And most importantly, if someone has hyperreflexia, clonus, and a Babinski, lumbar imaging is not helpful because they have a cord level issue, not a cauda equina type of problem. Here, at the very end of the spinal cord, we call it the conus, and at the same axial level in that canal, we have both spinal cord and nerve roots. So you produce both an upper motor neuron and potentially a lower motor neuron like picture. So it's a little confusing, but they should still have hyperreflexia, clonus, Babinski, things like that. And most importantly, I mean, even if you get a lumbar MRI, the conus is almost always included in that imaging. So if you're suspecting a conus level, you're still going to catch it. So really your decision is whether you need cord level imaging or cauda level imaging. Again, because there's rootlets at this level of this conus, you can still get a radicular type of pain in someone with spasticity in the leg and clonus and all that. So finally, three different things can happen when you have compression at the level of the cauda equina. So everyone's aware sort of an acute occlusion, like a large disc herniation, for example, or a big tumor might produce cauda equina syndrome. And so I won't go into that. I won't belabor that part today. Slow progressive occlusion can produce like a neurogenic claudication. We'll briefly go through that later. And individual nerve roots, if they're pinched, produce radiculopathy. And so those three clinical syndromes are what you can get out of the lumbar spine. So just to review here, so this is a T2 weighted sagittal MRI. Here's the vertebral bodies, the canal. You can see this is the spinal cord, and this is the conus. This is the end of the spinal cord around L1, and then these are all nerve roots. And so this is an axial section. I'm not sure if you guys can see my mouse here, but this is an axial section at the level of this yellow line. And the white is the CSF, the dark is the spinal cord here. And you can see a spinal cord with a couple of rootlets forming a nerve root on either side. And so compression here produces that, or anywhere at the cord above, for example, produces that spasticity or that clonus, that Babinski, that upgoing Babinski, that coordination deficit that we see in the cord level injuries. Down here at the conus, you can see it's spinal cord, and you see these little dots are the nerve roots. So this in this way, you can get both upper and lower motor neuron symptoms with pathology at that level. And down here, you get the very classic cauda equina-like picture. So this is the canal, and you can see here's an exiting nerve root, and this is the traversing nerve root, and all of these other little dots of these other nerve roots sequentially aligned. Out of interest here, I find this very interesting, so I thought I'd share it with you. These nerve roots are organized toward the dorsal midline. So if I flip this image to match what you'll see on the MRI, so imagine this is the L3 vertebral body, and this is the exiting L3 nerve root. You see the next one on deck here is L4, and the one after that is L5, and then S1, and they're organized in order toward S5 at the dorsal midline. And similarly on this side as well. And the MRI is so sensitive that you're not only seeing the nerve root, but you're seeing two little dots there. You're seeing both the motor and the sensory fascicles, motor being medial, that are about to comprise that actual nerve root. And so really the perineal symptoms, those symptoms that come from cauda equina, that distribution around the anus and the bladder problems, S2, 3, 4 type of nerve roots, really you need compression in this canal to affect this dorsal midline. That's where those nerve roots are. So a posterior lateral disc, for example, which affects the traversing nerve root, might produce pain and other symptoms related to the nerve root, but it's unlikely to cause true cauda equina-like picture. So in summary here, sorry guys, I have a phone going off in my office, but anything compressing the spinal cord above is going to produce those upper motor neuron symptoms, and anything below is going to produce the lower motor neuron symptoms. So I won't belabor cauda equina because I think everyone is pretty aware of it, maybe a separate talk, but I do want to say that cauda equina is pretty uncommon. I mean, we still see it relatively frequently through the emerge, but it is relatively uncommon, especially compared to something like myelopathy. So here's a classic case of someone who might have cauda equina. For example, a 28-year-old female here, acute bilateral radiculopathy, leg weakness, unable to ambulate, saddle paresthesia, bilateral complete, PVR, post-void residuals 800. And here you see obvious huge disc herniation obstructing the entire canal. This one's sort of a no-brainer. Standard of care from the spine surgery would be surgery within 24 hours. Best outcomes would be surgery prior to retention. I do find that sometimes this is a bit distracting. So if we could just get like an input or an audience poll, if you put a Y or a yes in the group text, if you think that bladder dysfunction or urinary dysfunction in the setting of spinal problems anywhere on the spine, is it more likely to be lumbar if you have urinary problems? So is there any way we can get a poll there? Not seeing much. So I just wanted to, we've got some questions developing. Yeah, maybe we'll save them for the end, guys. But yeah, very important. So the bladder dysfunction really can happen from spinal cord or cauda equina. And I think that especially the picture of cauda equina producing bladder dysfunction is so common and prevalent that sometimes people think that because there's bladder dysfunction, you should look in the lumbar spine. And I think this leads to a lot of workups with incorrect focus on the wrong area of the spine. So the actual micturition reflex is sort of complicated, a little above my head, but I'll give you the spine simplified version. So if you have an upper motor neuron picture, you've got a spastic, uncoordinated spinal cord and detrusor muscle function. The actual ability to compress the detrusor muscle and simultaneously, sorry guys, this is let's turn that off. Sorry about that. I've just got a bunch of faxes coming through. So the actual ability to compress the detrusor muscles and then simultaneously relax the sphincter are out of sync because they're uncoordinated. So they say that there's a detrusor sphincter dysenergia. And so end up with high bladder pressures and urgent incontinence and overflow and things like that. In cauda equina, it's really a lower motor neuron, neurogenic bladder. It's a low tone. They can't compress the muscles, and so they end up with, again, urinary dysfunction and overflow. So if there is bladder dysfunction, I'd say don't think about cauda equina. Think possibly spinal, and then if it is spinal, differentiate upper and lower motor neuron symptoms to determine that next step for imaging. Radiculopathy. So obviously, radiculopathy, I think everyone is not going to miss because pain produces such a reliable history. The patients can tell you right away the day that they started getting that pain, the onset, duration, severity, exacerbating, etc. And so I don't think anybody's going to miss it. I would just give caution in discharging patients that have radiculopathy without a true diagnosis. I'll show you some cases. So here's a 28-year-old male, for example, with an acute left leg radiculopathy to the lateral plantar foot. So you're thinking maybe S1, no weakness, no signs of cauda equina. And sure enough, there's an L5-S1 disc herniation, and it's a posterolateral disc affecting the traversing nerve root here. And so this patient, plan for them would be elective surgery. If they fail conservative measures, they can be seen in clinic. In contrast, here's a 55-year-old male with the exact same radiculopathy, no weakness, no red flag symptoms. And on his MRI, you can see diffuse infiltrative tumor at all these vertebral levels and these parasagittal cuts showing that it's really tumor compressing that the foramen and stuff like that. So it's an exact same clinical picture. This person has a very different disposition and plan, and they're getting admitted for workup and surgery and things like that. Here's a 51-year-old male with radiculopathy to the left thigh. So this patient just came in last week. So they were seen by the family doctor, had multiple presentations over I think months, and then finally came into emergency with progressive symptoms. And you can see sort of on the mid-sagittal CT, there's a diffuse multiple lytic lesions and pathologic fracture here. And here, and you can see the sort of, there's a couple of areas of spinal cord compression and deformity. So there's a lot going on here that has nothing to do with radiculopathy. And so I think it would be impossible to expect someone to come to this diagnosis, but the lumbar MRI did show this, which led to, full spine imaging, things like that. But I would just caution in discharging patients without a diagnosis, just having the clinical diagnosis of a radiculopathy, because again, anything that pushes on that nerve root, whether it's a tumor or a disc, is going to produce the same symptoms. Similarly for neurogenic claudication, so this is usually bilateral cramping, extension-based leg pain, posterior thighs, worse with activity, worse with walking, relieved in rest, relieved, with flexion. And the examination is usually normal, so they don't usually have weakness. Here's a 55-year-old female, bilateral leg cramping, worse in extension, worse with walking, partially relieved by flexion. Again, shopping cart signs. So she says, when I'm leaning over the shopping cart, I can walk through Fortino's for an hour and do all my grocery shopping. Without the shopping cart, I can only walk for 5 minutes. And she has no signs of cauda equina, no oculomotor neuron signs. And here you see the sagittal T2 weighted MRI, and you see fairly routine looking degenerative disease. And at the level of this red arrow, you have an axial cut here. And you can see, again, pretty routine disc bulge, hypertrophic facet, hypertrophic flavum, and no space for the nerves. And so this is a chronic issue. And so she has neurogenic claudication. Plan for her, she can come and get an elective surgery if she fails conservative measures from clinic. In contrast, here's a 78-year-old female, chronic back pain, progressive leg cramping, worsened extension, really sounds like neurogenic claudication. She does have a red flag on the history. So she's recently finished a 6-week course of antibiotics for discitis related to bacterial pneumonia. So then, definitely needs imaging. And you can see here, she's got active discitis and she's got epidural sort of abscess. So it's really failed conservative medical therapy. And now she's getting admitted for washout and decompression and all that. This one is a 55-year-old female, otherwise healthy, lower back pain, bilateral leg cramping, worsened activity, relieved of recumbency. She's neurologically intact. Really no red flag symptoms here. she's in Emerge complaining of neurogenic claudication. And you can see on the MRI, she's got pathologic fracture of L3, tumor involvement of L2 and L4. She's got this deformity with compression of the thecal sac. And so a very, you would have nothing on that history would really tell you that this is the lady who's going to have all this going on in the lumbar spine. But all you had was someone in Emerge with this neurogenic claudication picture, and this is what she had. And so obviously for her, she's getting admission and workup and surgical planning and all that. Remember, so anything that causes central canal stenosis can produce neurogenic claudication. And so that could be infection, tumor, degenerative process. And it is benign only insofar as that pathology that causes the stenosis is benign or degenerative. Okay, so finally, this is sort of what the point of the talk was on now is cord compression and myelopathy. So we've gone through some of the other syndromes that can happen. Here I'm going to start with cervical, and then we'll go to thoracic. So when the cervical spinal cord is pinched, you can really get a non-dermatomal numbness. So it's all 5 fingers and hands. It's a patchy sensory loss. It's a thick skin. And then there's loss of fine motor control. So we'll go into more detail after about what that means for different people, but fine motor can manifest in different ways. There's a loss of proprioception, which also manifests in very different ways depending on that type of person, and bladder dysfunction. There's often no pain. And so that's why this is such a tricky thing to come to diagnosis-wise. It's usually degenerative, but of course, anything that presses on the cervical spinal cord slowly and progressively can cause myelopathy. Here you see sort of a picture from the textbook. So the degenerative process and remodeling of the vertebral bodies and the disc bulges and all these things leading to compression of the spinal cord at multiple levels. And then so really it is a terribly difficult diagnosis to come to. And I racked my brain a little bit. I think it's for these reasons. So with the lack of pain, there's poor symptom recollection. So they don't tell you exactly when it started. They can't tell you really how it's progressed because they're not paying attention to it so well because it doesn't hurt. The symptoms themselves are, even in the most academic of patients, very difficult to articulate because they reflect an underlying loss of proprioception and dexterity. So patients are more likely to call themselves clumsy than to really attribute a loss of fine motor function to the hands. It's often very slow and progressive, so it's getting worse over years. And there's a difficulty in quantifying these things. So when you think about, we have no unit, like cognitively, you have no unit for proprioception. I can't tell you how much proprioception I've lost, right? So patients can only tell you landmark changes. I can no longer get dressed. I used to be able to button my shirts, and now I can't do that. Or very rudimentary things. I'm unable to use the knife and fork in a coordinated way to cut a piece of food. I used to walk independently. Now I can't walk. So you only end up with these sort of landmark changes in their activities of daily living. The clinical examination is often dependent on reflex testing, coordination, which is very hard to sort of detect sometimes in the emergency setting. Sometimes patients do have concurrent radiculopathy, so their whole focus and history is only about what they care about, which is the pain and that nerve root. And so they're not going to tell you about the other issues about dropping things. They're only going to tell you that pain shoots down the arm and it hurts and it's constant and it started here and it's progressed like this. And finally, the setting of diagnosis, catching these things in the emergency room when the diagnosis could be anything, is much more difficult than, for example, the spine clinic. The reason why it matters, so cervical myelopathy is 13 times more common than cauda equina. It's a leading cause of litigation in the United States, specifically related to misdiagnosis and delays of care. And then it's the actual #1 cause for spinal cord injury in the elderly. And so it's usually elderly patients presenting to Emerge and having a fall and ending up with central cord syndromes and things like that from pre-existing stenosis there. So I'm going to go through in a little more detail some of the symptoms with some examples. So when we talk about a loss of proprioception, and that manifests in different ways. So some patients have a lot of problems with balance and falls. And specifically, they'll comment on the stairs, so they need a handrail for the stairs. They have to watch their feet because they don't know where their feet are in space. And if they're not watching their feet on the stairs, they will fall. They drop objects with their hands, or they'll, instead of picking them up, they'll push them off the counter because they don't know where in space they need to put their hand to close it, to grasp the object without knocking it over. Their handwriting changes. This is also just sort of fine motor dysfunction. And then motor strength is usually hand dominant, but it's sort of a late finding that it would be the whole upper and lower extremities. The sensory deficit is sort of almost like a glove and stocking, so it's the whole hands. And then you can have patchy, dull skin, but it's not in a nerve root distribution. And then the bladder, they get that upper motor neuron bladder, so that sort of difficulty evacuating the bladder, having to go multiple times to get the bladder empty because of that detrusor sphincter dyssynergia. So certainly nobody in the emergency setting needs to know this, but this is something that sometimes we use in the spinal clinics. It's called the Modified Japanese Orthopedic Association MJOA score. And just to give you a sense that we're using these 4 categories, excuse me, to place patients into treatment groups. And so you're given a score at a 5 for upper extremity motor. And so you can see here that ranges from someone who's unable to move their hands all the way up to normal hand function. And you can see in between, we use things like able to use a spoon or eat with a spoon, button a shirt, things like that. We have a lower extremity sub-score where patients are able to, inability to walk, but have some movement, walk on flat ground, use the handrail, things like that. So it gives you a sense of progressively more normal walking. And then the upper extremity sensory, so complete loss of hand sensation all the way down to normal, and urinary function. And so there's a lot of, different patients, depending on what they're doing every day, are going to notice these problems differently. Obviously, the pianist here at the bottom is going to have a very different set of complaints and might notice different things. So she might notice the fine motor and the cadence of the fingers is different, whereas the construction worker might notice the strength in the hands first, and women tend to complain specifically about, let's say, eyeliner, difficulty putting on it because it's a very fine movement. Jewelry, specifically the necklace clasps, fastening a bra, and then job specific. So people who type a lot, they'll notice increased typing errors, decreased typing speed, texting errors, people on the phone a lot, dropping the phone, difficulty in dialing, things like that. So then you've got this sense of sort of what myelopathy is, and then I think an examination in the emergency room, to be useful, to be practical, has to be quick, simple, and the results have to be easily interpretable. And so when we go back to those upper motor neuron symptoms and lower motor neuron symptoms, I think we can say realistically, at least in the setting of myelopathy, increased tone is not going to be reliable in the emerge. You're not going to pick that up. And normal tone or flaccid tone, you're probably not going to pick that up either, really, unless someone has an obvious marked deficit. Normal power, I mean, this is also, it doesn't really tell you if that's a cord level lesion or not. Hyperreflexia, Hoffman, clonus are pretty good. And then sensory loss may be different in terms of having a sensory level, that may be good. And bladder dysfunction, again, doesn't really tell you where it's coming from. I sort of just thought in my head, these things here, these 4, I think could be done in the emergency room in a couple of minutes and really tell you if you're maybe investigating a lumbar spine when it should be a cord. So tandem gait obviously could be affected in anybody who could be anything, a knee problem, a hip problem, but someone with spinal sounding, maybe myelopathy, if they can tandem gait, they don't have myelopathy. And so I always get them to just get up and walk heel to toe, heel to toe, heel to toe. And then Babinski going upward, Hoffman, biceps, knee jerk, just tapping the patellar tendon with your fingers. It's very easy to tell if someone has a really brisk reflex in the leg. And clonus is very reproducible and very easy to do. I just check clonus at the ankles. And so all of these things together really take only a minute or 2, and they can really, I think, give you some good information. So for example, like a young patient, non-specific weakness, subjective weakness, patchy sensory complaints, falls, you're not sure, this could be myelopathy, it's a very vague history as usual. Any of these signs, clonus, hyperreflexia, Babinski, unable to tandem gait, I would get cord level imaging, cervical thoracic MRI. So just to mention, not all myelopathy, of course, is an emergency, but any patient presenting to the emergency room with progressive deterioration from a myelopathy perspective needs an urgent spine consultation for sure. I'd say just off sort of an estimate, about 50% of these patients that we're seeing in the emerge with progressive myelopathy are getting surgery during that hospital stay, and the rest or most of them are getting surgery within weeks, latest months. And so that emergent status is really up to that treating surgeon, right? And so usually it's the trajectory of the decline that determines the urgency. So someone who's telling you, I'm getting worse over years and I just finally have come into emerge because something happened or whatever, now having trouble dialing the telephone or whatever. If they're getting worse over years, usually we do the surgery over years. Worse over days, we're doing surgery over days. And so generally that's the case, except for some of these emergency features. So loss of bladder function, significant changes in ambulation, clinically detectable weakness. In those cases, sometimes we just do surgery right away. So this is an example. This is a very young guy to have this problem. He's a 28-year-old male with 4 presentations to the emergency department. His initial complaint was falls without any other symptoms. Very tricky one to work out from that perspective. Subsequent complaints included bladder dysfunction, and he actually says his inability to evacuate specifically, worsening falls, dropping objects. He is admittedly a very poor historian, and he does have a psychiatric history, which makes this very difficult. But on examination, a very clear exam with hyperreflexia, sustained clonus in both ankles. He's got unilateral Babinski upward. He's unable to barely walk, let alone tandem gait. Although his power testing is 5 out of 5. If you test him, the myotones in bed one by one. Sensory testing does show he's just sort of non-specific, but says there's sort of patchy sensory loss throughout. And so they get a CT scan in the emerge, and not much to comment on, or radiology doesn't see anything. Eventually gets the MRI, and you can see here this sagittal T2 weighted image. There's sort of a disc herniation here, and there's this cord signal change here, and you can see on that axial cut, really this degenerative process here causing, there's not a lot of space. He's got a congenitally narrow canal with a little bit of disc herniation, and now he's got really severe disease. And so he was admitted for an urgent decompression infusion just recently. Here's a 55-year-old female who came into the emergency department with radicular pain to the left arm. She is, so just as a contrast here, she's got complaints of weakness in the arm with sensory deficit on the shoulder, but really no signs of myelopathy. So she's got normal reflexes. She can tandem gait, although the arm hurts. And you can see here a very similar picture. She's got this disc herniation, but you can see on that axial section here that the disc doesn't hit the cord, it hits the nerve root. And so this lady can be treated in a very different way because she doesn't have the myelopathy, she doesn't have those upper motor neuron symptoms, she just has the radicular symptoms. And so here she can be referred to clinic, and if her symptoms don't resolve with conservative measures, then she can be sort of treated electively with a decompression or whatever. Here you have a patient with both. So it's a 62-year-old male with a left arm radiculopathy to the dorsal forearm and thumb. So you're thinking maybe C6, falls, no bladder incontinence or other symptoms. On exam though, he is limited motor exam in left upper extremity, mostly due to pain, radicular loss of sensation, C6. He is hyperreflexic. He's got a positive Hoffman. He cannot tandem gait. And here you see that disc herniation with both compression on the nerve root and on the cord. And so this patient has sort of myeloradiculopathy, or the combination of myelopathy and radiculopathy. Here, a 48-year-old male with progressive numbness in the hands, dropping objects, balance problems, decreased dexterity, trouble with buttons, pretty classic, and he's worse over days. Here you see fairly normal looking x-rays. And you can see on that MRI, really compression of the spinal cord here. And when you get that CT scan, you can see that this patient has ossification of that posterior longitudinal ligament again. Sorry guys, my phone's going off again here. So again, this patient has a cord compression, progressive myelopathy, and they get admitted for a decompression infusion. sorry, 1 second. And so, okay, here there's a 50-year-old male with progressive loss of dexterity. Notice that a change in his handwriting. He's dropping objects. His fingertips are numb in both hands. He has had a gait disturbance without falls. He's now using a walker, but was previously independent 5 months ago. And he's worse, he says, over weeks, otherwise healthy. X-rays look fairly benign. You can see maybe a little extra bone formation here. This MRI, though, you can see cord compression all the way down, and that axial sequences confirm that. And then on the CT scan, you can see again another patient with that OPLL. And I mean, the OPLL diagnosis doesn't matter, really. Just picking up the cord compression is the most important thing from the emerge perspective. So this patient was admitted for workup and OR. So again, the patient concern is going to be the radiculopathy. And to us, I mean, we're going to manage that electively and try to manage it conservatively. If, however, the clinician's picking up that myelopathy picture, that's much more important. So some of the physician-guided questions that I ask the patients in emerge, specifically because they will not characterize it for you, is have you been dropping objects? Are you able to button a shirt? Are your fingertips numb? Have you noticed a change in your handwriting? Have you noticed a change in your balance? Are you able to empty your bladder? Have they had any accidents or incontinence? Are they able to climb a flight of stairs without watching their feet? Do they need the handrail when they're climbing stairs? Do they use a walker or furniture or other aids around the house? So the next part is the thoracic myelopathy. So if you compress the cervical cord, at least you get hand symptoms. The thoracic myelopathy, you don't have any hand symptoms. You still have all the same symptoms in the lower extremities, but it's even harder for patients to characterize it because you can imagine quantifying losses of dexterity in the hands. At least I have strength and things like that for landmark. How do you quantify a loss of proprioception in your feet? You know, it's very difficult. Patients are very poor historians with regards to this. So they still do, however, have falls and balance issues and patchy sensory changes, and the same tandem gait, knee jerk, and clonus and Babinski apply. And I'll show you a few cases here. So this is a 58-year-old male presenting with lower extremity weakness, falls, unable to ambulate independently for 3 weeks, relying on the furniture. Prior to that, no radiculopathy, no urinary symptoms. He's pretty weak, like anti-gravity throughout the lower extremity. Clear hyperreflexia, clonus, Babinski. And I just want to comment, this patient's been at St. Joseph Hospital for 2 weeks and just came to us 3 days ago. So like, this is not, you know, under medicine. This is a tough one to pick up, really. And so they're trying to figure out why they're weak. And so we have a lumbar imaging, which of course we know based on that physical examination is not going to be useful. And the lumbar is going to show something though. And so it's going to show a little disc herniation and whatever, some pyramidal stenosis, stuff like that. Definitely not the cause for the problem. And you can see the patient has a big tumor on the thoracic spinal cord. And so you can see how easy it is to have a delay to care or misdiagnosis there when that lumbar imaging is normal. And so a patient was brought in for surgery and for the workup. Here's a 45-year-old female with recurrent falls. She does have a region above the umbilicus where she says it feels different, so like a sensory level, thick skin in the leg, so real decreased sensation. So no urinary incontinence, saddle, lower extremity radiculopathy, anything like that, no upper extremity symptoms. And she had 3 presentations to the family doctor and just came in last week to the emergency room. And oh, sorry, this is actually came in several months ago. This is obviously, I couldn't track down the MRIs from Kitchener-Waterloo, but she had this obvious on the CT, this big calcified thoracic disc herniation. And you can see the space for the cord is here, very minimal space. You see it really progressive thoracic myelopathy from this and was brought in for surgery. So just to go back to that initial case we talked about, the first case from the presentation, that was a 39-year-old female presenting with that non-specific constellation of symptoms. Lower back pain, which is especially a red herring because she had thoracic pathology, but everyone has lower back pain. Falls, urinary urgency, no perineal symptoms, no upper extremity symptoms, review systems negative, otherwise healthy. And then on her exam, she had dull sensory deficit, both legs, non-dermatomal. She's able to move her legs, but she is a bit weak, and her rectal tone's intact. The pertinent history here on the exam is that sensory level in the abdominal area, the recurrent presentation for falls with multiple workup from the lumbar, which would be normal, and then the urinary symptoms. From her exam, she's unable to walk without holding her partner, and certainly not able to tandem gait. She's quite spastic with sustained clonus and hyperreflexic with the Babinski, and she's in urinary retention. And so again, this is her MRI, and she had multiple presentations for falls. So some of the learning points here. So I'm thinking cord compression, young patient with function much lower than expected. So I think cord compression, and then those upper motor neuron signs. So just in summary, guys, the radiculopathy and neurogenic claudication, they're only benign if the pathology that causes it is benign. Anything compressing a nerve root causes sciatica, whether it's in the arm or the leg. And anything compressing the central lumbar canal can cause neurogenic claudication. Cauda-Equina syndrome, I think, is on the radar. However, cord compression is 13 times more common. Cauda-Equina syndrome, I think, is unlikely to be missed because the deficits are quite pronounced, especially compared to myelopathy. However, myelopathy is the most common cause for elderly spinal cord injury, and it's a leading cause for litigation. And I think recognition in the emergency room is challenging. I say check for the red flags in that history and physical, and perform a specific history for signs of cord compression, and don't expect the patient to articulate a loss of proprioception. So ask them if they've had falls, hand dysfunction, non-dermatomal sensory loss, hand weakness, dropping objects, bladder dysfunction. Don't think about cauda-equina if there's bladder dysfunction. Think this could be spinal. Is it upper? Is it cord level, or is it lower? Is it cauda? And then look for the specific signs of cord compression. So look for the hyperreflexia, the clonus, Babinski, Hoffman, and tandem gait. And remember, you don't need objective weakness to have progressive myelopathy. Thank you very much, guys. So I think if you want to go to some of these questions.
Yeah, so we can start off with from the beginning. So one question was, should we always image the total spine? If weakness is localized to lower extremities, radiology will often request L-spine MRI only.
So this is the issue, right? So someone with thoracic cord compression is going to have lower extremity weakness, and someone with cauda-equina is going to have lower extremity weakness. And so I think first and foremost, you have to say, okay, don't categorize it by lower extremity weakness, because again, that's non-specific. Look for those specific signs. So are they hyperreflexic with clonus? Do they have some sign of cord compression, right? Or do they have only lower motor neuron signs? Do they have radiculopathy with perineal symptoms, something like that would explain it? So neurogenic claudication and central canal stenosis don't really produce weakness, right? It's only, it's only in the most severe forms that you actually get weak in the legs from that. But you should be able to detect on the clinical exam when it comes to those reflex testing and all those other signs, if this person is has spastic legs or sort of flaccid and lower motor neuron type legs. And so if you can, on the clinical exam or on the history features, get something that suggests first, is this weakness from cord level or weakness from lumbar level, that would dictate your investigations. Because I don't think it's feasible to get a whole spine MRI. Radiologist is going to push back. It's going to be a waste of resources and things like that. So I think it really comes down to trying to figure that out beforehand.
Okay. Another question, if we suspect a myelopathy, should we start with CT over MRI? I think you answered that.
Yeah, I think that we looked at a few cases, though. The CT may show you, but it doesn't rule out if it's CT's negative. So the CT may show you there's something there. For example, sometimes you can see the shadow of the disc, but it doesn't tell you enough to be able to treat them. They still need the MRI, you may see certain pathology, but you can't be certain. So I'd say you still need the MRI. I guess the question really comes, and this is where you guys are really stuck in the emerge setting, is when it comes to these after hours things, how are you going to get the MRI? Do you need it tonight? There may be some way to sort of bring them back, get it done in the morning. Like it's not like a life or limb type of thing here, but they do need some imaging, and so is it something that could be coordinated over the next 24 hours or whatever, right? Yeah.
Okay. What post-void residual do you start to get worried about?
So everyone's different. The literature value is 250 cc. So someone with signs of cauda-equina and a PVR of 250, they say that's 99% specific for cauda-equina syndrome. However, some elderly patients with big prostates and lax bladders may have a resting PVR of a couple of hundred. You know, a young patient who's healthy should have a PVR of 0. So like in a healthy 20-year-old, a PVR of 200 matters. But the cutoff, technically, they say 250. But I'm not stuck on that. You know, it depends on the clinical picture. But definitely a 90-year-old with a PVR of 250 or 200 or 150, I'm not so concerned about compared to the 20-year-old who should definitely have a PVR of 0.
What plan do you recommend for a radiculopathy NYD, since we can't get MRIs for these?
So this is the biggest risk, right? So the radiculopathy, not yet diagnosed, is, I mean, you might be able to get them into a spine clinic just based on the history. It's very hard. Most of the surgeons that pick up the phone through Critical Call are not going to want to take the patient without a diagnosis. I think that if you spoke with your radiology colleagues, maybe they would say, okay, we'll agree to do it over the next week, and that patient could come back to Emerge to get the results and get a referral if their symptoms are still there. I think just sending someone out, sending them home, sending them to physio. We just saw one case in this presentation where the patient was going to their family doctor 3 times with radiculopathy, and it was a tumor, you know, and she had several months delay of care because, you know, you really need that diagnosis. So I guess it depends what environment you're in. Like if you're in a community hospital, if you're at the Hamilton General, it's sort of different, but I think you need to find a way to somehow get that imaging over a reasonable time frame, over a few days or a week or whatever, and then have them come back to Emerge, get them into the clinic, you know. Only once in a while. It's not all the time. It's only once in a while, but it's a tumor and it's not a disc, you know, and it's a young guy with a major problem or an infection or something like that, and it would be inexcusable to send them home based on their radiculopathy, right?
Okay. Another question is acute foot drop due to radiculopathy. How urgently should they be seen, followed up?
So this is a controversial issue. So chronic foot drops, not a lot of surgeons are operating on them for the purpose of restoring the foot drop because it's unlikely. It's a 50-50 kind of thing. But acute foot drops, they've got very good outcomes. And so if someone has a young, healthy person has a foot that's not working and a disc that's on that nerve root within 3 to 6 weeks, the results are very good if you get that disc out. So I put them on the board and operate quickly on those. Some people are different, so it sort of depends. It's a kind of a controversial subject, but I certainly treat them quickly. So if you called and I picked up the phone and you've got an acute foot drop, I would get them for sure seen within a week and sorted out that way.
Okay, I think those are all the questions. Now, I just had one, just going back, you know, we see a lot of radiculopathies in the ER, and I mean, I gotta say, I send a lot home. They usually come in for pain, and you know, their motor function's okay, and usually it's sort of, if it's like acute or, you know, they've only had it for a week, I think probably a lot of us send home and say, if it's persistent, follow up with family doctor to get an MRI.
I think that's fair. Like most of the time, like as long as they have a plan to get some imaging, you know, because like someone who comes in with a radiculopathy and it is a disc, often it resolves before they even get an MRI and they don't need that care. But we look at it differently from this. Let's say you're part of the spine team at the general, like we're the end of the line. So I always have to have that imaging because, you know, if I miss it, there's no one else to get it. And so all I see are the misdiagnosis. So I have a selection bias when I see these things, right? I don't see it from a family practice perspective where they see 10,000 people with radiculopathy and they're able to save the system a lot of resources by not ordering those tests. Like as long as somebody's watching it and somebody's able to follow up on that, whether it's a family doctor or whatever, somebody is going to make sure that if this patient is going to get imaging within a reasonable time frame, especially if they're getting worse, and look after it, right?
Okay, yeah, there's some comments here just about how it's difficult from an emerge point of view to coordinate these MRIs, and it's for emerge, it's hard to get these unless there is an acute spinal cord issue. Now, is there any sort of clinic or anything we can refer as an outpatient for these sort of, or do they really need imaging first before you guys see them?
Yeah, like I guess the issue is that they'll end up in the spine clinic and they don't have a spine diagnosis sometimes. And so then they get mismanaged because we're so focused on spine. We look at the MRI and we say there's nothing there, don't worry about it. But that patient still has issues that would need to be sorted. So, for example, somebody gets sent in, had a patient get sent in with what sounded like clear-cut sort of cord compression, and there was maybe something on the CT. We're waiting for the MRI, and by the time they arrived, I got the MRI. They were under me. They had Guillain-Barré, and I had them under me for 6 months. And so, I mean, I don't manage that, and I can't get them over to someone. I just have consulting teams now, and you can imagine that sort of picture where you end up with someone who is, really not managing it from a generalist perspective, right? So I think it's important to get that imaging if possible. We do, I think there some people have mentioned here like QI. This sounds like a QI initiative, et cetera. Like I think it's a good point that we have a major access issue to imaging, and we have a major problem because there are certainly cases all the time that are coming in that where diagnoses are getting missed because we just don't have access, and I think that that's something that we definitely need to look into. I think for the purpose of this presentation, someone who comes in with progressive myelopathy sounding symptoms, I think they need to stay in hospital until they get their imaging. And just because they have 5 out of 5 strength, testing the actual muscle groups down the legs in the emergency room, and they can walk with help, I don't think we should necessarily be sending them home. If someone really is getting worse, young, healthy person with cord compression, and they're very spastic, and I mean, we can't get access. I think we just need to keep them until we get the imaging. Someone says, would they get admitted under spine or medicine if you haven't had imaging? Sometimes it's hard to get the MRI, but they can't go home. Or do you keep them in ER? I mean, I guess it depends on who's working that day. But generally, when someone has weakness not yet diagnosed, I recommend they go to medicine because, like I said, like it could be Guillain-Barré still, it could be all these things. It could be like something totally different. And then once the MRI shows this is a surgical issue for the spine, then we usually take them over and care for them. Did I miss any questions there, Rob?
No, I think that's all of them.
Yeah. Guys, so
enough.
sorry that my phone's been going off. I got some messages. I'm sorry. I wasn't anticipating having the constant phone ringing for 60 minutes. So sorry about that.
Any final questions here? You can shout them out or write them down while you can. I got to say this was an excellent talk. I think this was very helpful, and we definitely appreciate you coming here. Getting a lot of thanks coming up here in the chat. Hope you can see those.
Yeah, that's great.
Very useful, very informative.
Yeah.
So on behalf of everyone, thank you so much for doing this, and thank you for being there also to help us out if we have these cases on call.
Absolutely, yeah.
And there's an evaluation for everyone. There's the link. If we could all fill that out. And again, thank you.
Yeah, no worries, guys. Thanks a lot for having me, and we'll sign off here. Thanks, guys.